What are the FDA pregnancy categories and how do they influence medication use during pregnancy? Answer. The FDA categorizes medications based on their risk to the fetus when used during pregnancy. These categories range from A, safest, to X, contraindicated due to evidence of fetal harm. The categories are: Category A, adequate studies in pregnant women have not shown a risk to the fetus. Category B, animal studies have not shown a risk, but there are no adequate studies in pregnant women, or animal studies have shown a risk, but human studies have not. Category C, animal studies have shown an adverse effect, but there are no adequate studies in pregnant women, or no studies have been conducted in women or animals. Category D, there is evidence of risk to the fetus, but the benefits may outweigh the risks in certain situations. Category X, studies have shown fetal abnormalities, and the risks clearly outweigh any possible benefit. These drugs should be avoided during pregnancy. When prescribing medications to pregnant women, healthcare providers must carefully consider the risks and benefits, selecting medications that are the safest while addressing the medical needs of the mother. For example, CE inhibitors, category D, may be avoided during pregnancy due to risks like fetal kidney. What are the main teratogenic effects of medications during pregnancy, and how can these effects be minimized? Answer. Teratogenic medications can cause malformations in the fetus if taken during critical periods of development. Some key teratogenic drugs include thalidomide, associated with limb malformations when taken during the first trimester; isotretinoin acutane, known for causing severe fetal defects like craniofacial anomalies and central nervous system defects; alcohol can cause fetal alcohol syndrome, leading to growth retardation, facial abnormalities, and intellectual disabilities; antipileptic drugs, e.g., valproic acid, phenytoin, may cause neural tube defects, cognitive delays, and congenital malformations. To minimize teratogenic effects, healthcare providers should prescribe the lowest effective doses, use medications with known safety profiles during pregnancy, e.g., folic acid for neural tube defects, recommend alternatives for high-risk medications, e.g., switching from valproic acid to lamotrigine for women with epilepsy. MS Lopez, a 30-year-old pregnant woman at 12 weeks gestation, is diagnosed with epilepsy. She is currently taking valproic acid for seizure control. The obstetrician informs her that valproic acid is a category D medication associated with a risk of neural tube defects. MS Lopez is worried about the risks to her baby, but is also concerned about controlling her seizures. What steps should the healthcare provider take to manage MS Lopez's medication during pregnancy? Answer. The healthcare provider should consider the following steps. Assess the severity of MS Lopez's epilepsy. Determine the frequency and severity of seizures, as uncontrolled seizures pose risks to both the mother and the fetus. Discuss potential alternatives. Consider safer alternatives such as lamotrigine or levetiracetam, which have a low teratogenic risk. Lamotrigine is considered safer during pregnancy and is commonly used in pregnant women with epilepsy. Consult a maternal fetal medicine specialist. If switching medications is necessary, consulting a specialist can help balance seizure control with fetal safety. Ensure proper prenatal care. MS Lopez should be given folic acid supplementation, 4 mg daily, before and during pregnancy, as folic acid can help reduce the risk of neural tube defects, a concern with valproic acid use. Monitor closely. Close monitoring of both maternal and fetal health throughout pregnancy is essential. The goal is to balance the control of MS Lopez's seizures with minimizing the risk of fetal harm, adhering to the principle of benefit versus risk in obstetric pharmacology. What are the primary factors influencing the choice of analgesics during labor, and what are the implications of using opioid versus non-opioid options? Answer. The choice of analgesics during labor is influenced by multiple factors, including stage of labor. Early labor may benefit from non-opioid options, e.g., nitrous oxide, while more intense labor pain may require stronger opioids, e.g., morphine, fentanyl. Maternal health conditions like obesity or respiratory disease may limit opioid use due to increased risks of respiratory depression. Fetal safety. Opioids cross the placenta and can cause neonatal respiratory depression or withdrawal symptoms if used too close to delivery. Patient preference. Some women may prefer non-pharmacological methods like epidural anesthesia or hydrotherapy. Opioids are effective in providing analgesia, but they come with the risk of maternal sedation, respiratory depression, and neonatal withdrawal. In contrast, non-opioid options like epidural analgesia or regional anesthesia provide effective pain relief without the systemic effects of opioids. Describe the role of regional anesthesia in obstetrics and its common complications. Answer. Regional anesthesia such as epidural or spinal anesthesia is commonly used for pain relief during labor and cesarean delivery. The role of regional anesthesia includes pain management during labor. It provides significant relief while allowing the mother to remain awake and active during the birth process. Cesarean delivery. Regional anesthesia is preferred over general anesthesia for elective and emergency cesarean sections because it reduces the risk of complications such as aspiration pneumonia. Common complications include hypotension. The block can cause vasodilation, leading to low blood pressure, which can be managed with IV fluids and vasopressors. Post-dural puncture headache occurs if there is accidental puncture of the dura during spinal anesthesia. Inadequate pain relief. Sometimes the block may not be effective in certain areas or in patients with abnormal anatomy. The risk-benefit analysis must be considered, especially for patients with conditions like spinal deformities or bleeding disorders. What are the critical considerations when administering antibiotics to neonates, and how do dosages differ based on weight? Answer. When administering antibiotics to neonates, the following critical considerations must be kept in mind: immature liver and kidney function. Neonates have immature organ systems which affect drug metabolism and clearance. Therefore, lower doses and longer dosing intervals are often required compared to older children or adults. Drug choice. Common antibiotics like ampicillin, gentamicin, and penicillin are used for treating neonatal infections, with choices based on the suspected pathogen, e.g., Group B Streptococcus. Pharmacokinetics in neonates. The volume of distribution and half-life of drugs can vary greatly. For instance, neonates have a higher proportion of body water, so hydrophilic drugs may require higher doses per kilogram of body weight. Weight-based dosing. For example, gentamicin is typically dosed at 2.5 mg every 24 hours in neonates, but adjustments are made for preterm infants or those with renal impairment. Regular monitoring of drug levels is crucial to avoid toxicity, especially with drugs like gentamicin, which can cause ototoxicity and nephrotoxicity. How does a family history of genetic conditions affect prenatal genetic counseling, and what is the role of pedigree analysis in this process? Answer. A family history of genetic conditions is a critical factor in prenatal genetic counseling. A detailed pedigree analysis helps identify potential inherited disorders and estimate the likelihood of passing them to offspring. The key steps involved in genetic counseling include assessment of family history. Counselors gather information about hereditary conditions such as autosomal dominant or recessive disorders, X-linked conditions, or conditions like hemophilia. Calculation of risk. The pedigree helps calculate the probability of inheritance, allowing the counselor to provide the family with a clear risk assessment, e.g., a 25% chance of inheriting an autosomal recessive disorder. Prenatal testing options. For families with a history of conditions like cystic fibrosis or sickle cell anemia, prenatal testing such as CVS or amniocentesis may be offered to detect genetic abnormalities. Informed decision-making. Counseling helps families make informed decisions about prenatal testing, considering both the risks and benefits. Explain the procedure, indications, and risks of chorionic villus sampling, CVS, and compare it to amniocentesis. Answer. Chorionic villus sampling, CVS, is a diagnostic procedure typically performed between 10–13 weeks of gestation to obtain a sample of chorionic villi from the placenta for genetic testing. Procedure. A catheter transcervical approach or needle transabdominal approach is guided using ultrasound to obtain the sample. Indications. Advanced maternal age, 35 years at delivery. Positive results from non-invasive prenatal testing, NIT. Family history of genetic disorders, e.g., cystic fibrosis, Tay-Sachs disease. Risks. Miscarriage risk, 0.22%. Infection. Limb defects, rarely if performed 10 weeks. Comparison to amniocentesis. Timing. CVS is earlier 10–13 weeks versus amniocentesis 15–20 weeks. Sample type. CVS collects placental tissue, whereas amniocentesis collects amniotic fluid. Detection scope. Both detect chromosomal abnormalities, but amniocentesis can also assess neural tube defects via alpha-fetoprotein. CVS provides earlier diagnostic results, but carries a slightly higher risk compared to amniocentesis. Mr. and Mrs. Patel are expecting their first child. Mrs. Patel's prenatal ultrasound at 20 weeks reveals increased nuptial translucency. Her doctor suggests additional testing due to a family history of Down syndrome. What options should the healthcare provider discuss with the Patels, and what are the pros and cons of each testing method? Answer. The healthcare provider should discuss the following testing options. Amniocentesis. Pros: detects chromosomal abnormalities with high accuracy, 99%, can measure AFP to assess neural tube defects. Cons: performed later in pregnancy, 1520 weeks, with a miscarriage risk of 0.1%. Non-invasive prenatal testing, NIT. Pros: uses maternal blood to analyze fetal DNA for trisomies like Down syndrome. Safe with no risk to the fetus. Cons: screening, not diagnostic. A positive result needs confirmation via invasive tests. Chorionic villus sampling, CVS. Pros: provides earlier diagnosis, 1013 weeks. Cons: slightly higher miscarriage risk, 0.22%, does not assess neural tube defects. For the Patels, NIPT could be a first step due to its safety, followed by amniocentesis for confirmation if results are positive. What are neural tube defects, their causes, and the preventive measures recommended during pregnancy? Answer: neural tube defects at EDS are congenital anomalies arising from improper closure of the neural tube during embryonic development by 28 days of gestation. Common NTDS include spina bifida, incomplete closure of the spinal cord and vertebrae, anencephaly, absence of major portions of the brain and skull, encephalocele, protrusion of brain tissue through a skull defect, causes genetic predisposition, maternal factors, folate deficiency, uncontrolled diabetes, obesity, certain medications, e.g. valproic acid, preventive measures, folic acid supplementation. All women of childbearing age should take 400-800 mg. Prenatal screening, maternal serum AFP and detailed ultrasounds between 16-18 weeks. Medication review. Avoid teratogenic drugs during pregnancy. Mrs. Rodriguez delivers a baby boy at 38 weeks gestation. During the newborn's assessment, you notice high-pitched crying, irritability, increased muscle tone, and tremors. The mother admits to using prescription opioids throughout pregnancy for chronic pain management. What immediate steps should the healthcare team take to assess and manage the newborn, and what long-term considerations are necessary for neonatal abstinence syndrome (NAS? Answer: immediate steps. The first step in managing a neonate with suspected neonatal abstinence syndrome (NAS) is to perform a Finnegan neonatal abstinence scoring system assessment to evaluate the severity of withdrawal symptoms. This includes scoring based on factors such as crying, irritability, tremors, muscle tone, feeding difficulties, and respiratory issues. A detailed maternal history is crucial, including documentation of opioid or other substance use during pregnancy. It is important to screen the mother for any additional substances using urine toxicology tests, and if needed, the newborn can be tested via urine or meconium to confirm opioid exposure at supportive care. Neonates with NAS require a quiet and low stimulation environment, as excessive noise and light can exacerbate withdrawal symptoms. Swaddling the neonate tightly, providing frequent feedings, and ensuring proper hydration are essential, as NAS may be accompanied by difficulty feeding and gaining weight. Breastfeeding is encouraged unless contraindicated due to illicit drug use or infection. Pharmacologic treatment. If the Finnegan score remains high, usually above 8, pharmacologic therapy is indicated. Oral morphine or methadone is commonly used to manage severe withdrawal symptoms. The medication dosage is gradually reduced to minimize withdrawal severity. Long-term considerations. Follow-up is necessary to monitor developmental milestones. NAS infants are at increased risk for neurodevelopmental delays, so long-term neurodevelopmental support and regular pediatric evaluations are crucial. Social workers may also be involved to ensure a safe home environment. Guidelines and laws. The American Academy of Pediatrics emphasizes the importance of individualized care for NAS infants involving both pharmacologic and non-pharmacologic interventions. State laws may require reporting suspected cases of child abuse or neglect to Child Protective Services, especially in cases of illicit drug use. Explain the pathophysiology, risk factors, and management strategies for transient tachypnea of the newborn TTN. Answer: pathophysiology. Transient tachypnea of the newborn TTN is a respiratory condition characterized by rapid breathing tachypnea in the neonate, typically presenting within hours of birth. The condition arises due to delayed clearance of fetal lung fluid, which can occur when the baby does not expel enough lung fluid during the birth process, especially in cesarean section deliveries. This retained fluid leads to pulmonary congestion, impairing gas exchange and causing rapid, shallow breathing. The risk factors: cesarean delivery. Infants delivered via C-section without prior labor are more likely to experience TTN due to the lack of the physiological process of labor that helps expel lung fluid. Precipitous or rapid delivery. Babies born quickly may not have adequate time to clear lung fluid. Maternal diabetes or asthma. Both conditions increase the risk of TTN, as they can affect lung fluid dynamics in the neonate. Management. The majority of infants with TTN experience mild and self-limited symptoms that resolve within 4-8-72 hours. Oxygen therapy may be provided to maintain oxygen saturation levels above 90%. Supportive care, such as feeding support and maintaining a neutral thermal environment, is critical. It is essential to rule out other causes of respiratory distress, such as respiratory distress syndrome (RDS), using diagnostic tools like chest X-rays to differentiate TTN from more serious conditions. Guidelines. The Neonatal Resuscitation Program (NRP) and AAP guidelines advocate for the careful management of TTN, emphasizing monitoring and the use of oxygen therapy as necessary while ensuring that more severe conditions like RDS are ruled out. A term neonate is delivered in a birth center with a room temperature of 18 deg. Describe the mechanisms by which neonates lose heat and explain strategies to prevent hypothermia immediately after birth. Answer: mechanisms of heat loss. Neonates are highly vulnerable to heat loss due to their large body surface area relative to body weight and their inability to regulate temperature effectively. There are 4 primary mechanisms through which neonates lose heat. Conduction. This occurs when the neonate comes in direct contact with a cold surface, such as a cold examination table or stethoscope. Convection. Heat is lost to cooler air currents in the environment, such as drafts or air conditioning. Evaporation. Moisture on the skin, such as amniotic fluid or sweat, evaporates, taking heat with it. Radiation. Heat is lost to nearby objects that are cooler than the neonate, like windows or walls. Prevention strategies. Conduction. Immediately dry the neonate after birth to remove wetness and prevent heat loss. Use a pre-warmed radiant warmer for the initial stabilization period. Convection. Maintain the room temperature at 22 to 25 they can avoid air drafts. Consider using a hat to prevent head heat loss, as the head accounts for a significant amount of body heat loss. Evaporation. Dry the neonate quickly after delivery, particularly the head, which retains moisture. Radiation. Place the neonate near a heat source or in a radiant warmer to prevent heat loss to nearby cold objects. Guidelines. The World Health Organization, WHO and AAP recommend the warm chain approach, which includes immediate drying, delayed cord clamping, and maintaining a warm environment, especially for preterm or low birth weight infants. What are the benefits of breastfeeding for neonates, and how can healthcare providers support mothers experiencing difficulty with breastfeeding? Answer: benefits for neonates. Breastfeeding offers unparalleled nutritional benefits. Breast milk contains the perfect balance of nutrients required for optimal neonatal growth and development, including proteins, fats, carbohydrates, vitamins, and minerals. It contains immunoglobulins IgA, which protect the infant from infections by boosting their immune system. Breastfed infants experience lower rates of gastrointestinal infections, respiratory infections, ear infections, and SIDS. It promotes the development of the neurodevelopmental system and enhances bonding between the mother and infant. Support strategies for mothers. Latching techniques. Teach mothers proper latching to ensure effective milk transfer and prevent nipple trauma. Frequent feedings. Encourage on-demand feeding and ensure the baby is feeding at least 1-2 times per day in the early weeks. Breastfeeding counseling. Provide continuous support and education to address concerns like low milk supply or sore nipples. Lactation consultant referral. For mothers facing challenges, refer to a lactation consultant who can assist with positioning, latch issues, or concerns about milk production. Guidelines. The American Academy of Pediatrics and World Health Organization, WHO, recommend exclusive breastfeeding for the first 6 months of life, continuing alongside complementary foods for up to 1 year or more. For a premature infant born at 28 weeks gestation, describe key neurodevelopmental support strategies in the Neonatal Intensive Care Unit (NICU). Answer: minimizing stress. Premature infants are at high risk for neurological stress due to their immature nervous system. Neonatal Intensive Care Units (NICUs) should be equipped to create a low stimulation environment. This includes keeping the lighting dim, using soft or white noise, and limiting physical handling to necessary procedures. Developmental positioning. Neonates born before 32 weeks gestation should be positioned in flexion, mimicking the fetal position. Positioning aids such as rolled towels or pillows can help maintain appropriate postural alignment and reduce the risk of musculoskeletal deformities. Kangaroo care. Skin-to-skin contact. Kangaroo care has been shown to have multiple benefits for premature infants. It regulates temperature, stabilizes heart rate and respiratory rate, improves weight gain, and promotes neurodevelopmental outcomes. The mother or father should be encouraged to provide kangaroo care for as many hours as possible each day. Nutrition. Early and adequate nutrition is crucial for brain development. Breast milk is the preferred source, and fortified breast milk or parenteral nutrition (PN) may be necessary for extremely premature infants. The goal is to achieve a growth velocity that mimics intrauterine growth. Guidelines. The AAP and National Institutes of Health emphasize the importance of early, individualized neurodevelopmental interventions and a multidisciplinary team approach to support the long-term development of premature infants. What are the common causes of neonatal jaundice, and what management strategies are recommended for its treatment? Answer. Causes of neonatal jaundice. Neonatal jaundice occurs due to an excess of bilirubin in the blood, resulting in a yellowish discoloration of the skin and sclera. Common causes include physiological jaundice, due to immature liver function, typically appearing between days 2-3 of life and resolving by day 7-10. Breastfeeding jaundice occurs due to inadequate breastfeeding in the first days of life, leading to dehydration and decreased bilirubin excretion. Hemolysis. Conditions like blood group incompatibility, e.g., Rh or ABO incompatibility, or spherocytosis can increase red blood cell breakdown, leading to excess bilirubin. Infections. Sepsis and other infections can impair bilirubin conjugation and clearance. Management strategies. Phototherapy, the mainstay treatment for jaundice. Blue light therapy converts unconjugated bilirubin into a more easily excretable form. Exchange transfusion. In cases of severe hyperbilirubinemia, total bilirubin 20 dl, or signs of bilirubin encephalopathy, an exchange transfusion may be required. Adequate feeding. Encourage breastfeeding or formula feeding to ensure adequate hydration and promote bilirubin excretion. Guidelines. The AAP provides guidelines on managing neonatal jaundice, recommending monitoring bilirubin levels closely, especially in at-risk infants, and using phototherapy as the first-line treatment. Describe the pathophysiology, clinical presentation, and management of respiratory distress syndrome (RDS) in preterm infants. Answer. Pathophysiology. Respiratory distress syndrome (RDS) primarily occurs in preterm infants whose lungs are insufficiently developed. The condition is caused by a deficiency in surfactant, which normally reduces surface tension in the alveoli and prevents lung collapse. Without adequate surfactant, the alveoli collapse during exhalation, leading to impaired gas exchange, hypoxemia, and respiratory acidosis. Clinical presentation. RDS typically manifests within hours of birth in preterm infants, with symptoms including tachypnea, nasal flaring, grunting, intercostal retractions, and cyanosis. Management. Surfactant replacement therapy. Administering exogenous surfactant to preterm infants with moderate to severe RDS helps reduce surface tension in the lungs and improves lung compliance. Mechanical ventilation or CPAP. For severe cases, positive pressure ventilation or continuous positive airway pressure (CPAP) is used to maintain lung inflation and improve oxygenation. Oxygen therapy. The neonate may require supplemental oxygen to maintain adequate oxygen saturation levels, typically 90%. What is patent ductus arteriosus (PDA) and how is it managed in preterm infants? Answer. The ductus arteriosus is a fetal blood vessel connecting the pulmonary artery to the descending aorta, allowing blood to bypass the lungs. After birth, it typically closes within a few days. PDA occurs when this vessel remains open, leading to abnormal blood flow between the aorta and pulmonary artery. Pathophysiology. In preterm infants, the ductus arteriosus may remain open due to immature muscular wall, low oxygen tension, elevated levels of prostaglandins. PDA can cause left-to-right shunting of blood, leading to pulmonary overcirculation, heart failure, and compromised systemic perfusion. Clinical presentation. Symptoms vary with the size of the PDA and include tachypnea, feeding difficulties, murmur on auscultation, poor weight gain, signs of heart failure in severe cases. Management strategies. Medical management. Indomethacin or ibuprofen NSAIDs. These drugs inhibit prostaglandin synthesis, promoting ductal closure, fluid restriction. To reduce pulmonary edema. Surgical ligation. If medical therapy fails or the PDA is large and symptomatic, surgical closure may be necessary. Guidelines. The European Society for Pediatric Research (ESPR) and AAP recommend early screening for PDA in preterm infants and initiating treatment based on clinical and echocardiographic evidence. What are the risk factors, clinical features, and management of necrotizing enterocolitis (NEC? Answer. Necrotizing enterocolitis (NEC) is a serious gastrointestinal disorder characterized by inflammation and necrosis of the intestinal tissue, primarily affecting preterm infants. Risk factors. Prematurity, most significant risk factor. Formula feeding, breast milk is protective, hypoxia, ischemia, infection, immature immune system. Clinical features. feeding intolerance, abdominal distension, bloody stools, lethargy, and apnea, progression to peritonitis and sepsis in severe cases. Management strategies: medical management, NPO, nothing by mouth, discontinue enteral feeding, parenteral nutrition, to provide necessary nutrients, antibiotics, broad-spectrum antibiotics to treat or prevent sepsis, supportive care, including IV fluids and ventilatory support as needed, surgical management, indicated for intestinal perforation or extensive necrosis. Procedures include bowel resection or stoma creation. Guidelines: the use of probiotics has been suggested to reduce the risk of NAC in very low birth weight infants, although their use should be based on institutional protocols. What is retinopathy of prematurity, ROP, and how is it screened and treated? Answer: ROP is a disorder of the developing retinal vasculature in preterm infants, leading to abnormal blood vessel growth and potential retinal detachment. Risk factors: low gestational age, low birth weight, prolonged exposure to high levels of oxygen, sepsis, or other comorbidities. Screening for ROP is recommended for infants born at 30 weeks of gestation, birth weight 1,500 grams. Regular ophthalmologic exams starting at 4-6 weeks, postnatal age or 3 weeks, postmenstrual age. Treatment: laser photocoagulation, the standard treatment to stop abnormal vessel growth. Anti-VEC therapy, intravitreous injections, e.g. bevacizumab, to reduce vascular proliferation. Surgical intervention, reserved for advanced cases with retinal detachment. Guidelines: the American Academy of Ophthalmology and AAP recommend timely screening and treatment to prevent severe visual impairment. What is the primary role of HPV testing in cervical cancer screening, and how does it influence the management of patients with abnormal Pap smear results? Answer: human papillomavirus HPV testing plays a crucial role in cervical cancer screening, particularly in identifying high-risk HPV strains such as HPV 16 and 18, which are known to cause cervical cancer. HPV testing can be used as an adjunct to Pap smears or as a primary screening tool for women over the age of 30. Impact on management: when a Pap smear shows atypical squamous cells of undetermined significance or scarce, HPV testing helps to determine the necessity of further diagnostic procedures. If the HPV test is negative, the patient may not need additional follow-up, while a positive HPV test, especially for high-risk strains, indicates the need for colposcopy and possibly biopsy to assess for cervical dysplasia or carcinoma. Guidelines: according to the American Cancer Society and the American Society for Colposcopy and Cervical Pathology Act, women aged 30 and older should undergo testing, Pap smear and HPV test every 5 years. For those with a scarce and a positive HPV test, further diagnostic workup is necessary to assess for high-grade lesions or malignancy. Explain the stages of ovarian cancer and discuss the implications for treatment and prognosis at each stage. Answer: ovarian cancer is staged using the FIGO International Federation of Gynecology and Obstetrics staging system, which categorizes the disease from stage I confined to the ovaries to stage IV distant metastases. Stage I cancer is confined to one or both ovaries. Treatment involves surgical staging and removal of the ovaries and uterus, total hysterectomy with bilateral salpingo-oophorectomy, followed by chemotherapy, usually with paclitaxel and carboplatin. The prognosis is generally favorable with a 5-year survival rate of approximately 90%. Stillman 2 cancer has spread to the pelvic structures but is still within the pelvis. In addition to surgery, chemotherapy is typically used. The survival rate drops with a 5-year survival rate around 70%. Stillman cancer has spread to the abdominal lining or distant pelvic organs. Cytoreductive surgery to remove as much of the tumor as possible is followed by chemotherapy. The survival rate for this stage is significantly lower, approximately 3950%. Stillman or distant metastases occurs often to the liver or lungs. Treatment may include chemotherapy and, for certain cases, targeted therapy or immunotherapy. Prognosis is poor with a 5-year survival rate of about 1720%. Sarah, a 28-year-old pregnant woman in her second trimester, is receiving prenatal care. During a routine visit, she mentions that she has been experiencing more stress and recently had an argument with her partner, but she denies any physical abuse. As part of her comprehensive prenatal care, how should the nurse proceed with screening for domestic violence, and what steps should be taken if the patient is found to be at risk? Answer: in this scenario, the nurse should adhere to evidence-based guidelines for screening for domestic violence (DV) during pregnancy, such as those provided by the American College of Obstetricians and Gynecologists (ACOG). Screening process: Routine screening should be conducted in a private, non-judgmental setting, ensuring confidentiality. The nurse should ask direct questions such as, "Have you ever been hurt by someone in your life?" Or, "Do you ever feel afraid of your partner?" But these questions should be asked using a trauma-informed approach to avoid triggering distress. Action if risk is identified. If the patient discloses domestic violence or is suspected to be at risk, the nurse should offer resources, such as a domestic violence hotline or local shelter. The nurse should collaborate with social workers or counselors for support and ensure that safety planning is provided. Reporting. The nurse should follow state and institutional laws regarding mandatory reporting of domestic violence, if applicable, while ensuring the patient's confidentiality and safety. The nurse should also discuss the potential risks of DV to maternal and fetal health, including preterm labor and low birth weight. What are the main side effects of chemotherapy used for gynecologic cancers, and how can these be managed in the patient undergoing treatment? Answer. Chemotherapy, commonly used for gynecologic cancers like ovarian, cervical, and endometrial cancer, can have several side effects. These include nausea and vomiting, one of the most common side effects. Management includes antiemetic medications, e.g., ondansetron or dexamethasone, as well as non-pharmacological interventions like ginger or acupuncture. Fatigue, often persistent during treatment. It can be managed with energy conservation techniques, adequate nutrition, and encouragement of light physical activity to prevent deconditioning. Bone marrow suppression. This can lead to neutropenia, thrombocytopenia, and anemia, increasing the risk of infections, bleeding, and fatigue. Treatment may include growth factor support, filgrastim for neutropenia, and blood transfusions for severe anemia. Hair loss, alopecia. This is common with agents like paclitaxel and cyclophosphamide. Discussing options such as wigs, hats, or scarves is helpful for emotional support. Mucositis, painful sores in the mouth and digestive tract. Management includes oral hygiene, saltwater rinses, and topical treatments like lidocaine gel for pain relief. Discuss the importance of timely vaccination during pregnancy and the associated benefits for both mother and baby. Answer. Vaccination during pregnancy is crucial to protect both the mother and the developing fetus from preventable diseases that can cause severe illness. The most important vaccinations during pregnancy include Tdap vaccine, recommended between 27 and 36 weeks of gestation to protect against pertussis. Whooping cough. Pertussis can be fatal for newborns, and maternal vaccination helps to transfer antibodies to the fetus, offering protection during the first months of life. Influenza vaccine. Pregnant women are at increased risk of severe complications from the flu. COVID-19 vaccine. The CDC recommends the COVID-19 vaccine for pregnant women, especially those who are at higher risk of severe disease. The benefits of vaccination during pregnancy include protecting the mother from infections that could compromise her health and pregnancy, providing the infant with passive immunity through the placenta, reducing the risk of infections in the first few months of life before the infant can be vaccinated. Explain the current guidelines for screening cervical cancer, specifically addressing the role of pap smears and HPV testing. Answer. The current guidelines for cervical cancer screening, as established by the American Cancer Society Acts and the U.S. Preventive Services Task Force include pap smear. For women aged 21-29, it is recommended that a pap smear be performed every 3 years. Pap smears are used to detect cellular abnormalities in the cervix that may lead to cancer. HPV testing. For women aged 30 and older, that ACS and USPSTF recommend co-testing with both a pap smear and HPV test every 5 years, or a pap smear alone every 3 years. HPV testing helps identify high-risk HPV types that are linked to cervical cancer. Stopping screening. Screening may be discontinued for women aged 65 and older who have had consistent negative results over the past 10 years. Women who have had a total hysterectomy with removal of the cervix for non-cancerous conditions also do not require further screening. The primary aim of these screenings is to detect precancerous lesions early, allowing for intervention before cancer develops. The role of HPV testing is crucial in identifying women at increased risk for cervical cancer, particularly those infected with high-risk HPV strains. Dr. Carter is treating a 56-year-old woman diagnosed with stage I endometrial cancer. The patient has been recommended to undergo both surgery and chemotherapy. However, she is hesitant about chemotherapy due to concerns about the side effects. What should Dr. Carter discuss with her regarding the importance of chemotherapy and its role in improving her prognosis? Answer. Dr. Carter should provide the patient with comprehensive, evidence-based information about the role of chemotherapy in treating stage I endometrial cancer, chemotherapy's role Chemotherapy, typically with a combination of drugs like paclitaxel and carboplatin, is used to treat endometrial cancer when there is a risk of the cancer spreading beyond the uterus. In stage I, while the cancer is still confined to the uterus and cervix, chemotherapy can help reduce the risk of recurrence and improve survival rates. Prognosis and survival. Chemotherapy significantly lowers the likelihood of cancer returning after surgery, improving overall survival. Without chemotherapy, the risk of recurrence in stage I endometrial cancer is higher, especially if the cancer is of high-grade. Side effects. Dr. Carter should also discuss the common side effects of chemotherapy, nausea, fatigue, hair loss, and reassure the patient that these can be managed with supportive care. The decision to pursue chemotherapy should weigh the potential benefits, reduced recurrence, improved survival, against the temporary side effects. Dr. Carter should ensure that the patient feels supported and that her concerns are addressed in the decision-making process. What are the main risk factors for abuse during pregnancy, and how should healthcare providers screen for domestic violence? Answer. Risk factors for abuse during pregnancy include history of abuse. Women with a previous history of domestic violence or sexual abuse are at higher risk. Young age. Adolescents and women under the age of 25 are more likely to experience intimate partner violence. Substance abuse. Alcohol and drug use by either the woman or her partner increases the likelihood of abuse. Stress and economic hardship. Financial instability, unemployment, and lack of social support are significant stressors that can trigger abusive behavior. Pregnancy and ambivalence. The pregnancy itself may increase stress, and partner violence may escalate due to controlling behaviors surrounding pregnancy. Healthcare providers should screen for domestic violence at every prenatal visit using direct and indirect questioning in a private setting. The use of validated screening tools like the Hurt, Insult, Threaten, and Scream HITS scale can help identify women at risk. Healthcare providers should maintain confidentiality and offer support resources if abuse is suspected. Explain the rationale for smoking cessation counseling during pregnancy and the potential complications associated with maternal smoking. Answer. Smoking cessation counseling during pregnancy is crucial due to the numerous risks smoking poses to both maternal and fetal health. Smoking increases the risk of preterm birth. Nicotine and other chemicals restrict blood flow to the placenta, leading to an increased likelihood of preterm birth. Low birth weight. Smoking reduces fetal oxygen supply and nutrient delivery, resulting in smaller than normal babies. Placental problems. Smoking is linked to placental abruption, where the placenta separates from the uterus, and placenta previa, which can lead to heavy bleeding. Long-term health problems for the child. Infants born to mothers who smoke are at higher risk for respiratory issues, asthma, and developmental delays. Healthcare providers should offer evidence-based strategies for smoking cessation, including behavioral therapy, nicotine replacement therapy, with caution and support from community resources. The goal is to reduce smoking as early in pregnancy as possible to improve maternal and fetal health. What is the role of radiation therapy in the treatment of gynecologic cancers, and what are the potential side effects associated with it? Answer. Radiation therapy is a common treatment for gynecologic cancers, particularly in cervical, endometrial, and vaginal cancers. It is often used after surgery to eliminate any remaining cancer cells or as an alternative to surgery in certain cases. Indications. Radiation is used for localized cancers that have not spread to distant organs, or in cases where surgery is not possible due to the patient's health status. It is also used as adjuvant therapy to reduce the risk of recurrence. Side effects. Acute include skin irritation, fatigue, nausea, and bladder or bowel issues. Long-term can lead to vaginal dryness, fibrosis, infertility, and sexual dysfunction due to the effects on surrounding tissues. Management of side effects. To manage these side effects, symptomatic treatments such as vaginal moisturizers, anti-nausea medications, and pelvic floor rehabilitation are used. Radiation therapy can significantly improve survival rates and reduce the risk of recurrence, but it must be carefully managed to minimize its long-term effects on fertility and quality of life.